Good afternoon, everyone. It is so nice to see so many people logging in right now. I, on behalf of the PCOS Society and Vijayata, welcome you to another edition of the panel discussion for PCOS and infertility. Without further ado, let me introduce you to the panelists that are there today. Dr. Mirudhubashini. What can I say about her? She's a veteran. She graduated from the Stanley Medical College, Chennai. She did her PG training at University of Manitoba, Winnipeg, Canada. Former training faculty at University, teaching hospitals in Winnipeg, Canada. Former associate professor, examiner for national boards, clinical director for Women's Center Coimbatore, speaker at national and international conferences, author of several publications, member of the ISAR, ESHRE, ARMAN, FOXY, EMA, CII, Healthcare Panel Coimbatore. Best Women Entrepreneur Award for Coimbatore Management Association, Inspiring Gynecologist of India 2018 by the Times Group, Lifetime Achievement Awards by Tamil Nadu and Pondicherry Chapter of India Society for Assisted Reproduction, TAP IASR for 2022. The next panelist that we have with us is Dr. Ramya Jayaram. She is also she's a PDF in endocrinologist. She's an alumni with PSG, IMS, and R. Fellow on Gynecology, Fellow with Reproduction Medicine, MGR University. Advanced training in Operative Hysteroscopy, MGR University. Has been trained under Dr. V. Venkatesh, Dr. P. M. Gopinath, and Dr. Sailesh Putambar. Has undergone reproductive medicine training under Dr. Mirudhubashini Govindarajan. Currently heading the Department of Endogynecology and Reproductive Medicine at Women's Center by Motherhood, Coimbatore. The next speaker that we have is Dr. T.R. Sindhuri. She is MS ONG, postdoctoral fellowship in reproductive medicine, and a consultant at the Reproductive Medicine's Women's Center, Hospital, Coimbatore. And the last speaker is Dr. Abineya. She is also an MS ONG, again a postdoctoral fellowship in reproductive medicine and a consultant in reproductive medicine, Women's Center and Hospitals, Coimbatore. Without delaying this entire talk any further, the discussion any further, allow me to introduce you to these lovely panelists, and I hope you all enjoy the entire discussion. And please have the questions coming in, because this is all for you, by you, and that's how we are going to be able to know where we stand. Over to you, doctors.
Hello for the audience out there of PCOS Society, all India wide. This is Dr. Mirudhubashini Govindarajan from Women's Center Coimbatore and my team of reproductive endocrinologists. This is one of the first units of ART which started in India and has been doing a lot of work on reproductive medicine. So each one of my doctors in here are all qualified in reproductive medicine and reproductive surgery as well. So let me just start introducing all of them. Dr. Ramya, by my right, is a person who's qualified and a fellow in both reproductive medicine and reproductive surgery, which is endoscopic surgery and everything related to surgery to improve fertility in a woman. And besides that, I have Dr. Sindhuri to my left and Dr. Abineya to my right. As a team, we look after all these problems day in and day out. So I think we'll be happy to discuss this topic, which is polycystic ovary syndrome, which seems to become a puzzle for a lot of people all over. Okay, there's a lot of confusion out there in the public. There's a lot of confusion out there even within the professional society. So I think we want to bring some clarity to this subject. And to start with, let me start with saying that polycystic ovary syndrome is actually was a name given to this entity about nearly a century ago. And it was at a time when people didn't understand what the problem was, but today we understand a lot more about this issue and this problem. And so therefore, even the name polycystic ovary, PCOS or PCOD, has become superfluous and probably inappropriate as well. Because if you look at PCOD, it's not a disease, it's a syndrome. And it doesn't pertain to ovary. It's a systemic syndrome where the metabolism, otherwise it's the functioning of different organs becomes different. And polycystic is many cysts in the ovary, and we now very well know that there are no cysts in the ovary, and these cannot be called polycystic. It is more likely many follicles in the ovary rather than many cysts in the ovary. So time has come that we've got to go beyond this, and we will, as we discuss, we'll tell you where we are going now. It's almost like a perpetual stage of puberty in an individual. And there are three main things that happen in PCOS. One is the ovulation in a woman. In other words, when she's producing an egg every month, that does not happen regularly. Second problem is androgenization. In other words, some features of male hormones being present in a woman. And the third is an ultrasound picture of the ovary. Okay. Now, the first two are much more important than ultrasound picture of the ovary. We now know that ultrasound picture of an ovary does not make a diagnosis of PCOS, and as we go along, we'll explain it to you. So the more important factors are lack of ovulation or lack of cycles coming regularly, and androgenization in some, which is a little bit of a male hormone imbalance in which women get more acne, more hair growth, and more male distribution of fat and these kind of things. Anyway, we'll start with the clinical problems that we face. So the problems to do with, even though to do mainly with fertility, it's much beyond that. And where people concerned with fertility do show up to us in several different ways, even from adolescent onwards, because that's what they gain out of the public. Okay. So, and there are many, many situations we have to calm them down and tell them that it is just a hormonal imbalance, a metabolic imbalance, and by correcting those two things, we can take care of the majority of situations and almost have this person lead a normal life. But if it is uncared for, what happens is, in the adolescent, there is periods which are totally irregular, and sometimes the male hormone features like increased hair growth, pigmentation around the neck, and all these things happen as well. And in the reproductive age group, majority of them come to us with a problem because they're not ovulating and the cycles are happening regularly. It can also have an impact in the older age group where the hormonal imbalance and the metabolic imbalance gives rise to other problems like diabetes, increased incidence of endometrial cancer, breast cancer, and these kind of things. So I think we'll time now that we get into the clinical situations. The first one that I would like to start out with is the teenager that comes to us. Teenager that comes to us, now we know that class finishing students are put through all kinds of drills, +1, +2, 10th, 9th. They're put in boarding schools often. Their dietary pattern changes. Their objective changes. They are almost down to their books about 10 or more hours in a day. And with no exercise and no dietary control, whatever they're being fed in there, a lot of them, and the tension and the stress that is placed on them, a lot of them stop having their periods. And this is one situation that we often see these young girls. Ramya, do you want to handle this? How you would?
So I think, a lot of the times, we have very young girls coming in and we see that they are overweight and they have irregular cycles, and they have also these features like Madam mentioned, excessive hair growth, acne, and this is a big concern. But we also have girls who are very thin and also come with the same symptoms of irregular cycles, acne, and excessive hair growth. So you have these two spectrums. You have the girl who's overweight and has these features, and you also have the girl who's very thin and has these features. So what we need to understand is these two girls have to be handled differently. The girl who's overweight and has more abdominal fat and has these features of excessive acne and hair growth has a hormonal imbalance, which has probably been set off by this excessive fat deposition, which causes an offset of the imbalance and also other features related to that. So for that girl, we will have to think about a different way of handling her by bringing in lifestyle changes, by bringing in diet, exercise, and also sometimes medication may be required. And the girl who's thin and has the similar features has to be handled differently because she doesn't have the excessive fat which is contributing. She has primarily the imbalance, which could be genetic, and there may be other factors to it. And for her, we start off with medication, and then depending upon her response and how it goes, we handle it.
Another situation that we faced with fertility is now everybody is savvy about going back to Google and getting the information from Google. Okay, so this fairly pretty young girl gets married and her cycles are a little irregular and it's an arranged marriage. 3 months later, the husband brings her to me saying that I believe my wife has a problem called PCOS. Okay, she's inherited a problem. It wasn't told to me, they got her married to me. How fair or how right is this? This is because of Google the teacher. He goes there and he finds that PCOS leads to all kinds of these problems. It can lead to infertility, it can lead to cancers in later life, and it can lead to all kinds of other things. That is all he knows. He doesn't understand the disease. And he comes to us saying that it's somebody with an inherited disease. So first of all, our job is to make sure that they are reassured that it's not a disease, it's an inherited disorder, okay, where the hormones can be easily corrected and they can pretty well lead a normal life, okay. And a lot of other questions come to us as well, okay. And if you think of what else that you would like to talk about, and at a later age group also, is it gone or is it still there, or is it the hormonal imbalance still there? Could it have an effect on them even in later part of life?
So this patient, when she came, her cycles are irregular. So mostly we'll evaluate her any increased weight gain or any other history suggestive which is causing anovulation. So she needs a diet counseling and she needs a monitoring. Maybe we'll go ahead with the follicular monitoring and counsel her. And when this patient is not followed up for a longer period, maybe unopposed estrogen will have some effect on her endometrium, which will lead to endometrial issues in the later part of her life, along with the metabolic disorders.
I think also, these sort of scenarios, I think the husband and the family need to be counseled that it's not a disease, that it is basically an imbalance that has happened because of factors such as lifestyle, sometimes stress, lack of sleep, an undiagnosed, thyroid dysfunction. All of that can cause irregular cycles as well. And even, if she has that problem of this, hormonal imbalance, it is not going to affect her chances of conceiving any more than the next person. But they basically need to understand that, the only major issue is she's not ovulating on time. So she will need very simple medication that will make, that egg grow on time. They can try naturally. And, once they conceive under such, circumstances as well, the pregnancy can be as normal as somebody who's conceived spontaneously. There's no difference in the pregnancy going forward. So I think counseling is very important for the couple and also for the family around them to understand this condition.
If a child comes with irregular cycles, is this normal or abnormal, and when does it become abnormal?
Post-menarche of 2 years, the cycle irregularity is common, and it is because of the pubertal changes. And post 2 years of menarche, if irregular and associated with the hyperandrogenic features and any weight gain with excessive acne, it can relate to the hormonal changes. So these girls should be evaluated for the PCOS hormonal panel and should be corrected accordingly.
Nothing needs to be started right in the beginning. I think it can be a period of time where we can wait to see whether nature will spontaneously correct it. And if it's less than 3 periods after they are 17 or 18 in a year, then there may be a time that we have to interfere and correct their cycles as well. So irregular cycles per se don't need to be corrected very, very early on. A lot of parents have the explanation they anticipate the child when the child goes through menarche for the child to have regular periods. It does not happen. It takes a few years, as a matter of fact, and then it becomes regular as time goes on. So unless it persists beyond 16, 17 or 18 years, I don't think there's a really rush to go for hormonal analysis and all that. Is every obese child with irregular cycles a PCOS?
Not.
Say that.
They are not. Maybe even though they are obese, they might have a regular cycles. Just we need to monitor them for their physical health.
In other words, that is, even within professionals, it's a misconception that an obese child walks in there, obese child, girl child. She may be 14, 15 or whatever, and if she has irregular cycles, she immediately gets labeled as PCOS. So that doesn't require to be done. Can PCOS happen in one ovary? Ramya, you're a surgeon and you have.
So the fact that even it is possible that only one ovary can get targeted for based on the hormonal imbalance that happens. And again, to be able to define somebody as PCOS, again, you shouldn't take only the ultrasound into consideration. You have to take whether they have the irregular cycles, whether they have obvious features of the hormonal imbalance. You have to do certain blood tests to understand if it is there, to what extent it is there. So just having one ultrasound report saying that she's got the cystic appearance, and even if it is only in one ovary, I don't think we should directly label her as a PCOS. We should take the entire picture into consideration and then manage it accordingly.
Actually, out of the 3 things we talked about, at least 2 will have to be there, and the least important of them all is the ultrasound picture. Ultrasound picture. So sadly, sometimes it happens that a 16-year-old child has acute abdominal pain, possible appendicitis, and taken to a surgeon, and the surgeon orders for an ultrasound and diagnosed as acute appendicitis. When there's pelvic inflammation, the ovary changes as well. So the report may come from a radiologist as enlarged ovary, the suggestion of acute appendicitis, the right ovary enlarged and has multiple cysts, therefore polycystic ovary. And these panicking parents come to you and saying that the surgeon is going to be anyway operating on the appendix and taking the appendix away. Should he be operating on the polycystic ovary within quotes and taking the cysts away? Absolutely not. Okay, so one ovary and this kind of a thing, or even in a teenager, a radiologist saying that there is polycystic ovary cannot be accepted as a diagnosis. Making it even more simple, polycystic ovary is not an ultrasound diagnosis. It's a hormonal imbalance. So we have to look at the hormonal imbalance and also the metabolic imbalance. Okay, the overweight child with a PCOS is probably more predominantly metabolic imbalance, and more predominantly metabolic imbalance means they have higher level of insulin in their body. It may be dietary, it may be sedentary lifestyle, it may be everything else that we talked about, and when all that happens together, the cycles are going to be irregular. And the cycles are irregular doesn't immediately mean it, but at the same time you can't label them as this thing. But androgenization, which is the other change, I have to explain it a little, because androgenization means little excessive male hormones in a woman. Okay. Now, all males contain male and female hormones. All females contain male and female hormones. Okay. It's the proportion that varies. Okay. And if a male contains a bit more female hormones, it's an issue. The same way, if a female contains a little bit more androgenic tissue, it's an issue. That is when people start getting excessive acne in adolescence. And this is when they start getting hair growth in undesirable places, and where usually women don't get hair growth in their limbs or chest or back or things like that. So these are things that give you a little warning signal that the androgen levels or the male hormone levels, the proportion may be changed a little. It doesn't mean that she's become male kind of. It means that the hormone levels have changed a little bit, and they can be easily corrected with medications. So that is not an issue. So there are two things that a physician looks for: too much of male hormones and too much of BMI as well. Okay, and that is another. The metabolic change manifests as higher level of BMI. Higher level of BMI means that for their height, the weight is more. And when the weight is more, what is more important is where does this weight get settled down? Okay, and it's much more dangerous if the weight gets settled down around their midriff. Okay, around their stomach. Okay, and if the obesity, we do something called the waist, simple thing called the waist hip ratio. Does anybody want to talk about waist hip ratios?
Waist to hip ratio, it is measured like around 1 inch below your belly button is your waist, and the hip is the prominent area. So waist by hip ratio of 0.8 is normal. Anything above that, then it is considered as PCOS abnormal.
It could be intra-abdominal, it could be extra-abdominal. Okay, the fat can be inside the abdomen, or it can be just subcutaneous fat, like a roll. Okay, around below their umbilicus. Which one is worse? Inside the abdomen is worse. When they get the fat inside the abdomen, it has more metabolic consequences. Okay, it gives rise to what we call a metabolic syndrome, which is high levels of, they're much more prone for developing diabetes, they're much more prone for developing hypercholesterolemia, and all kinds of changes related to that. Okay, so I think you have to know not only whether the waist hip ratio is higher, you have to also judge and see whether it's extra or intra-abdominal kind of a thing, so because that also makes a difference.
So I think also another thing that we have to remember is when this fat, especially in the abdominal fat, it sort of is more resistance. It has more resistance to insulin, and once the insulin, so insulin is what breaks down the glucose in our body and uses it up. And when for these girls and women who have more abdominal fat, it becomes more resistant to insulin, so there is higher insulin levels in the body, and that also can set off changes at the level of the hair follicles. It can set off changes in the level of the skin, where they'll have more oil secretion, and that causes more hair growth and acne. So we've counseled a lot of girls by just losing 10% of their weight, or even 5 kilos, not even 10%. Even if they lose 5 kilos from where they are, if they lose 5 kilos of weight, that can cause major differences to their cycles and also to the excessive hair growth and the acne that they have as well. So I think lifestyle changes is primary, starting from weight loss.
Can you give some dietary and exercise clues to girls staying in a hostel?
So this is something that we hear very often, especially now that we are seeing, towards the exam, 10th standard students, 12th standard students, they finish their exams, and then after that their parents bring them and come saying that, she's gained about 5 kilos in a year or 5 kilos in 6 months. And, essentially because nobody gets up and moves other than, sitting and studying with their books. And I think society and, our education, this thing asks that of, young kids these days. So, what I normally tell them is, if you wake up normally at 6 or 7 in the morning, just wake up about half an hour earlier. Even doing about half an hour of cardio where you get your heartbeat up from if your baseline is 70, just bring it at least to about 100. And, just getting up and moving for half an hour, having, whatever you're having, reducing the portions of what you're having a little bit, especially the rice. So cutting down on carbs and cutting down on fat. So that has a lot of, impact on, it helps a lot with weight loss. Cutting down on sugar. So to make it simple, cutting down on anything white. So, white rice, cutting down on that, shifting to other millets, cutting down on white sugar, maida. So all these things which, come with eating outside, swigging and, ordering in food and eating all the time, or processed foods. So cutting down on all of that, and, we can't make major changes, especially when kids are studying in hostels and all of that. Major changes cannot be done, but cutting down on the portions and just getting up and walking for about half an hour may start making major changes.
I have darkening of my back and neck and arm fold and thigh fold. Is all this because of PCOS?
It's mainly due to the insulin resistance, which has a major role in causing this darkening of the skin in the necks and arm plexus. So this patient will be monitored with her blood sugars, and starting with medications will improve her this thing with weight loss.
Just because these ovaries are slightly big, do they undergo torsion?
Just these are small cystic follicles, and that doesn't cause any torsion.
Actually, some scenarios where this woman has enlarged ovaries, and then she undergoes something for ovulation induction, where we treat for fertility. We give certain drugs which make the egg grow on time. Sometimes if the dosage is not right for her profile, or sometimes when we're adding on injections to make more follicles grow, that time some women respond a little too much and the ovaries become enlarged, and in those circumstances sometimes the ovaries can undergo torsion. But otherwise, without these circumstances where they've had medication for these purposes, and ovary which is enlarged because of these multiple follicles doesn't necessarily undergo torsion.
Should schools from 9th standard to 12th standard, should they have a diet plan and activity plan, especially if they have hostels for girl children, incorporated with their regular activity?
Yes, ma'am. Since these students are studying for more than 10 hours per day, they need to have a proper diet and an activity plan. Either the activity can be scheduled either in the early morning or in the evening hours after the schooling. Minimum 30 minutes of regular exercise and around 3,000 steps of regular walking can help them. Along with the diet plan, since these are in boarding, maybe as ma'am said, a meal plan of once a rice-based meal and replaced by the millets or any sprouts, and all the vegetables and fruits can be an alternate options to avoid junk foods and nothing to buy from the bakeries or from outside, ma'am.
So a major replan of all the school feeding will be required. Does Ayurveda and Siddha help?
I think nothing really helps if the underlying problem is not taken care of. So, if the underlying problem is being, overweight, high fat deposition in the abdomen, in the thighs, and, your diet is essentially, high calorie, high carb, high sugar, high, processed food. If your essential lifestyle is like that and, you're sedentary, you're sitting in front of the TV, you're not doing much physical work, I think under those circumstances, no medication, whether it is Ayurveda, allopathy, homeopathy, nothing is going to work unless the underlying problem is taken care of.
So basically what all of us are saying is it's a lifestyle disease. It's an inherited genetic trait. It's not a disease. You inherit the trait. And also it's interesting for people to know that the trait is not inherited just from the mother. It can be inherited from the father's side as well. And once you have the trait, if your lifestyle is not okay, then you manifest all of these things. And depending on which is more prominent, you manifest all of those things. So this happens in teenager. And the young man who came to me with his wife saying that she's got this major disease, now what do I do with her, kind of thing. Anybody wants to advise her? Advise her.
He's telling...
You don't want to take that question. What? I mean, I want to do that.
I think ultimately it again comes back to counseling both of them as a family and trying to make the husband understand what the underlying issue is. And also a lot of the times we tell them that, let it not be only the wife, who's thinking that it's a problem and it's only her problem. I think, when it comes to fertility especially, it has to be a combined thing that, a couple does together. So I usually tell them, exercise together, everybody in the family incorporate the same lifestyle, healthy eating and exercising every day is not a bad thing. It's not something that only one person in the family has to do. I think, as a family, if everybody incorporates it, everybody benefits from it. So
the obvious things that we talked about, skin tags and the pigmentation and abdominal fat, do you think it's reversible?
Yes, ma'am, it's reversible. When your insulin resistance is fading away, then obviously your weight loss and everything will help her to ovulate, and when she's planning pregnancy, it will help her anyway.
Insulin resistance, like we said, to reinforce, it's either androgen levels which are very high or insulin levels which are very high. And each individual may have a different combination of these things, and accordingly we have to tailor their treatment. It's not just a standard treatment for everybody. And the commonest medication that we use.
Usually for the irregular cycles, we usually use the hormones, which contains both the estrogen and the progesterones. It is not mandatory that both should be given for a adolescent girl. Even we can manage them with the progesterone alone when her cycle irregularity is more problematic one. But once she is having an hyperandrogenic features, the progesterone only medications will not help her. So a combined pill can help her in managing her hyperandrogenism as well as her hirsutism and acne as well.
How should we be dealing with all these problems, Ramya? Is it really a doctor's desk and some 15 minutes of counseling, or should they have something called a PCOS clinic?
So, when it comes that PCOS is, a lifestyle issue and it is a metabolic issue, I think, just only the obstetrician handling it or alone will not be sufficient. I think we need a PCOS clinic where we combine a dermatologist, because sometimes, even there are certain conditions where the excessive acne and the excessive hair growth, it may not be, it may not completely respond only to medication. And it may not respond quick enough. So in those situations, for a young girl to have those problems, it may be better to include a dermatologist also to help her out. And again, when it comes to somebody who's very obese and who has metabolic problems such as, she has diabetes, she has, high cholesterol levels, bringing in some physician to handle that will be good. And, again, sometimes we are so busy, we don't have the time to sit and counsel a woman on exactly, what should be her calorie intake, what is she eating in a day, what is, per meal, what is the calorie count, what should be the minimum that she is taking, what is the maximum that she's allowed to take, and, how many calories should she be burning in a day. So, we don't have enough time, or even we don't focus on these things enough. And I think having a PCOS clinic where we involve all these people and, to help this person go to hell with this condition, handle it and overcome it and lead a better lifestyle will definitely benefit not only her but also her family and the community.
So basically what we're talking about is something that starts with a counselor, a dietitian, a physiotherapist, and a physician as well, to monitor the medications if you need to give. And not everybody needs to go on a lot of medications, but there are people who need to if they have to bring down the insulin level or if they have to bring down their androgen level, they may need medications for a period of time. Does not have to be a lifelong medication. It's until they have the problem under control and they can be then phased out of all of these things. Now there's another part of the discussion which was fertility actually. Okay, why do they come to us as fertility specialists? Why do they come to us? What is the main reason they come to us? And what can we do?
These couples, when they plan their pregnancy, they usually use these apps for tracking their ovulation, ma'am. So once they have their cycles getting delayed by around 50 days, 55 days, and their app doesn't showing properly, and even they don't know how to calculate where to plan their pregnancy, and they plan every week and they couldn't conceive for a few months, they come with the frustration. They ask us what to do. Then we tell them about the slow follicular genesis which happens in a PCOS, and we explain them how the egg growth happens and how they should correct their lifestyle changes which can help them to get it corrected by them. Or we can even aid them with the medications to get a proper follicle growth, and we can help them track their ovulation and can advise accordingly, ma'am, to plan their pregnancy.
Do they all have to go on serious infertility treatment like IVF or not?
No, I'm just based on the years of trying anyway the irregular cycles, they first need diet management and ovulation monitoring. Most people conceive with that itself. If there's other factor other than the anovulation, then they may need a fertility treatment.
So the first step, as you're saying, I would say is correction of the hormonal imbalance and correcting it in such a way that ovulation happens and they can conceive. And can these medications just be given to people and say that you go home and take it and try?
No, ma'am. It usually few couples the medication doses can vary among the people. So even one will respond very high to the normal dosage and one will not respond to the normal dosage. It is not proper to leave them without monitoring. So always we have to advise a proper one cycle of at least monitoring how they respond to the medications and adjust the dose accordingly so that they can plan for the next one or two cycles.
So basically not everybody responds to medications the same way, so they need to be monitored because monitoring is absolutely essential for these kind of things. So the simplest form of medications is oral medications, which will correct their cycles just enough for them to ovulate. And if those oral medications do not work, what would be the next step?
So we always try to follow a very systematic approach to this. So if oral medication is something, again, so which is why monitoring it is very important. We've had so many scenarios where women have taken medication outside, they've just taken it over the counter from a pharmacist, and then they come with problems where, she's responded too much, and again she's, she has severe pain and other complications. So it's very important that they're monitored closely. So the first thing that we always start with is lifestyle changes and oral medication. If that doesn't work, then maybe her profile is such that she may need a little bit more to make that follicle grow. So we'll add on injectables as well. And generally, again, the dosage of what injections we use, and what combination of injections we use, we decide based on the profile, how she responded in the previous cycles to just oral medication, what is her follicle count like, and regularly monitoring this couple, checking for the follicle growth, checking for the endometrium by an ultrasound. All these things are very important through the treatment cycle.
If they cannot come for a monitoring, would you use injectables?
Definitely no, ma'am. Because anytime this kind of patient can land up in hyperstimulation, and as madam said, this kind of PCO ovaries, if there are too much of follicles, there might be torsion, and she'll land up in OHSS risk. So it is better to avoid injectables when she's not able to come for a monitoring.
So injectables ought not to be used if there is no facility for monitoring. Okay. Does anybody ultimately require an IVF?
I think requiring an IVF depends not only because of the fact she's somebody with PCOS. I think you have to take everything into consideration, including the male partner's profile, how long they've been trying. So, if you see that, with medication, with good monitoring, she has good folliculogenesis, you've evaluated the uterus, seen that, everything is fine there, you've evaluated the tubes, everything is okay. Male partners, all parameters such as a semen analysis, seeing whether the DNA fragmentation in the sperm, which is another test which tells us about the capacity of the sperm to be able to form an embryo. So all these things are important. And if they've had multiple previous cycles which have failed, previous IVF cycles that have failed, so we don't consider IVF for somebody just because of the fact that she's a PCO and they've been trying for a while. We have to take everything into consideration before we take that next big step of going for an IVF cycle.
This again is somebody who's probably a bit more interested in regular exercising. I got married, this is an actual question. I got married last year, diagnosed with PCOS. Can I do exercise, Zumba, gym during my planning period?
Yes, ma'am. Mild and moderate exercises are allowed during your pregnancy planning period. Even they can continue with their Zumba, dance and swimming, everything. But once they get conceived, then the heavy lifting or the pelvic pressure exercises or need to be restricted.
What would be the ideal things to when they are exercising and trying to conceive?
So I think the biggest misconception is that people have is that when they're planning, treatment for fertility, when they're planning on conceiving, that they shouldn't do any sort of physical activity. They shouldn't even get up from the table and go do anything. They have to have somebody move their things around. So these are all very big misconceptions. For especially when we're talking about a profile of patients where the weight is on the higher side, that they need to be burning those calories. And they also have these issues because of their lifestyle. Not doing any work and being sedentary is very counterproductive. So it is very important that couples, both the husband and wife, follow a healthy lifestyle of exercise, good diet. The woman can exercise, they can do cardio, they can, if there's something that they're normally used to, they can continue that. But if they're going to start, just, before or during their fertility treatment, I think starting with at least walking, good brisk walking every day, maybe adding a little bit of strength training as well in the form of weights, just so that you're converting that fat into muscle. So I think, just starting with these exercises. And also, I think, instead of just looking at, we have all these patients who look at YouTube one day, do one set of exercises, then the next day they do another set of exercises without understanding what will work for their body and their profile. So I think also bringing in a physio and a proper trainer and a dietitian in this plan also will be helpful. And we always tell them, even when they're going through treatment, they can continue everything. And even after they're conceived, depending upon also, their profile, what sort of exercises they can and they cannot do.
I have been diagnosed of, this is another question, I have been diagnosed of PCO earlier, and my cycles are like every 50 to 60 days. And I would like to conceive as early as possible. Do I still have to wait the conventional 1 year before I start correcting?
No, ma'am. It is obvious that she has anovulatory cycles since her cycles are getting delayed more than 50-60 days. So it's better she can come back to us, get her hormone panel checked. If it is okay in the range, so that we can start our ovulation medications, we can start the medications along with the lifestyle changes, ma'am. No need to wait for the 1 year.
Another question. I took a scan as a routine checkup and it read as multifollicular ovaries, bilateral PCOS. What should I do?
So even though your scan image shows it's polycystic ovarian thing, if your cycles are regular, no need to panic. In case if your cycles are irregular, then you can come for a monitoring, which can be done with the fertility specialist.
I don't think we'll complete this discussion without talking about ovarian drilling. And Dr. Ramya is our surgeon here, and she can talk.
So I think there the biggest problem that we have among our medical community or surgical community is that the assumption that PCOS can be cured by drilling the ovaries. And the thing is, there is an underlying hormonal imbalance, and that imbalance has been set off by a lot of things. Like again, what we've been talking about, it's lifestyle, it's genetics, it's that excessive obesity, that fat which is in the body. So all these things have set off this imbalance, and imbalance has affected the ovaries and the way the ovaries function. So by puncturing the ovary, it is maybe temporarily that male hormone levels, the excessive hormones in the ovary may reduce a little bit. When I say temporary, the effect of one drilling lasts maybe about 2 to 3 months. But again, we have seen that time and again, after they get this done in about 2 to 3 months, all the same issues come back. The irregular cycles come back, the hirsutism comes back, the acne comes back. So, it doesn't go. So this is like a temporary thing that can be done. But also the biggest problem with that is it is also damaging the ovary. It is damaging the eggs in the ovary. And once it is damaged, it will not come back. We are all only born with so many eggs, and once you damage it with any sort of a surgical procedure, and especially with drilling, it doesn't come back. And we've had women who've had multiple drillings done because one drilling was done and it didn't work. Second drilling was done and again she had the same problems. And the third time when they come to us for fertility treatment, the reserve in the ovary is so low that we cannot do anything. That even our fertility treatment, our IVF cycles have not helped because the ovary has been damaged and the number of eggs in the ovary have been damaged. So if anybody suggests that a drilling has to be done for taking care or curing your PCOS, I think they should run in the opposite direction.
I think that's a good ending for what we are doing. I think we'll be available for the question answer session. We thank a lot the PCOS Society for giving us this opportunity to be front of a national audience, and we'll be only too happy to interact with them in any way desired in the future. Thank you.
Hi, what a brilliant discussion. I've actually have my book and my pen and I'm actually taking notes. Thank you so much, doctors. I think y'all have been phenomenal. Thank you so much, Dr. Mirudhubashini, for actually conducting this entire session. Dr. Ramya, you were outstanding. I think your answers were brilliant. Dr. Sindhuri, and thank you so much, Dr. Abineya. Thank you so much for being a part of this and actually, enlightening us with this topic, which more than half the women are very shy to talk about. I think everybody will agree with me when I say this. This has been absolute eye-opener for all of us. So now there are a lot of questions that are coming in from the general public, and a lot of people are asking lots of questions. So I'm not going to waste more time because we are anyway running short of time, and I'm going to start, the questions. Dr. Mirudhubashini and Dr. Ramya will be taking these questions. So here, just a second, I'll just open the thing for the question. Yes, here you go. This lady asking, is there any holistic approach to reverse PCOS without medicines?
The answer, I think, is that it's possible because, as we explained earlier, the genetic trait isn't going to be changed. You carry it with you for your entire lifetime, but your lifestyle determines a good portion of whether you become a manifested PCOS or not. So if your lifestyle changes have been adequate enough and you reach a certain goal and you're able to maintain it, you may not need any medications for all further.
Okay, Neha, I hope you got your answer. The next question is by Nahid. What about autoimmune disease and its affecting on beta signaling to ovaries?
Autoimmune, can you say that again?
How about autoimmune diseases and its affecting on beta signaling to ovaries?
No, that is not part of what PCOS is. As far as we scientifically understand it, it is not an autoimmune disorder. Autoimmune disorder occurs in somebody without any genetic trait, where a part of the body decides that it's going to act against its own body, like certain type of cells, and different kind of autoimmune disorders exist. PCOS is not one of them. It's almost like a diabetes or hypertension that runs in the family, or hypercholesterolemia that runs in the family. And we all know that in Indian society, all of these things are today very, very common. And this is such a similar thing. In Indian population, maybe about even 20% or 25% carries this kind of a gene. And it is your lifestyle that suddenly ultimately makes you a part of it or not, part of the manifest PCOS or not.
So lovely. I hope Nahid is happy. Sorry, please continue.
No, I think a lot of research is coming out now that, there's something called in utero programming that happens as well. So they talk about how, mothers who have PCO, the environment in the uterus changes, and it sort of programs the fetus also to, especially if it's a female child, the likelihood of her being PCO also increases. So it's more than, like Madam said, it's more than autoimmune, it's this sort of programming that happens.
And it can happen in utero, it can happen in adolescence, it can happen in certain stages of that.
So even if you are like at 40 plus or actually menopausing and all, can it still happen? Can it still happen at that point of time?
It usually is not common for somebody to become manifest of this later in life. And it's like a adolescence misguided.
Okay.
And that is the stage it happens most of.
Oh, okay, great. Nahid, I hope you've got your answer. The next question is coming by Ruba. So she says, my height is 5'4", my weight is 51 kilos, but not getting my periods regularly. I was under treatment of Dr. Shah since the past 2 years, but no improvement. Please help. I also do exercises 40 minutes daily.
So I think we need to just, we can't take only your BMI into consideration. I think we need to check your hormonal profile also, because, hypo or hyperthyroidism also can cause irregular cycles. Prolactin levels changes also can cause irregular cycles. So I think we need to understand, your hormonal profile and, taking in account also your BMI and other factors before we decide what is the reason for your irregular cycles and how to handle it.
Irregular cycles alone do not make PCOS.
Right. So I think, Ruba, you can go back to the doctor and she will, I'm sure, will be more than happy to help you again go through this. Indira has a question. Is it possible to get pregnant after 40? What could be the issues?
That is a totally different issue from PCOS. Your ovarian follicles, what you're born with, is about 500,000 inside the mother's uterus. In the female child, it's several millions, and at birth it's about 1 million or so. Comes down to about 500,000 even at the start of reproductive life in adolescence. By the time you reach your menopause, it's about 400 or something that's left in the ovaries. So there's a rapid decline in the number of follicles as you age, both in the number and the quality of the sites that you have become not so optimal. So that is the problem with aging. It's nothing to do with PCOS.
Great, Indira. I hope if you are planning to get pregnant, you will soon. Okay, then there's Janvi who has a question. How many IUI cycles we can try before moving forward with other options when all the parameters in my body is tested and are normal? Husband semen analysis is also normal.
So I think there's no golden number to say this is, after this you have to switch on. I think, we need to take everything into account. So, there are some things that can be picked up in investigations and some things that cannot be picked up. So in IUI cycle, we have no control to see whether the follicle ruptures on time and, what the quality of the egg which has ruptured, whether, when we inject the sperm inside, whether it actually reaches where it's supposed to, whether fertilization is happening, the quality of the embryo that is forming. So I think we need to also take into consideration the age of the patient, also, like I've spoken about in previously, there's something called DNA fragmentation which is a very current test that we're doing, to find out the capacity of that sperm to be able to form an embryo. So we're noticing that as men age and men in certain occupations, whether it's exposure to chemicals, fertilizers, etc., the damage increases, and that reduces the chances of a pregnancy. So I think more than giving a golden number, I think we need to look a little deeper and then decide when it's enough, when IUI is not working, and move on to the next step.
Okay, Indira has actually written back about about her conceiving at 40. She says, I have PCOD and I am not able to reduce weight. Is there something I can do about that?
So I think, yes, women with PCO definitely, because of a combination of insulin resistance, the fat, the areas where the fat is deposited, it is definitely a little bit more difficult to lose weight compared to somebody who doesn't have the hormonal imbalance. But it only means that, we have to change the way we eat, what we eat, also probably bring in a physio, a trainer to tell you exactly for your body type, what are the type of exercises that you should be doing. And, like I said, not randomly do one exercise every day. So, I think the way we go about exercising and what we eat also has to change for it to work.
Right. I hope Indira now finally got her answer. We have last two questions. One is, one person has asked, does PCOS happen to make you forgetful? So, does it, doctors? Please enlighten.
If you're concerned about it and you're not thinking about anything else, maybe it will.
I think we shouldn't use PCOS as an excuse for everything.
Okay, so yes, it doesn't, I guess so. Okay, so the last question is, any specific dietary supplement that helps with the egg quality?
I think there are many of them marketed and very few of them are proven. So I do not want to throw around the multiple names which are floating around as increasing oocyte quality particularly.
Okay. So there are several, but yeah, they have to speak to their doctors for it, right? Mm-hmm. Right. Great. So this was fabulous. We've got just going to see. I don't think we have any more time, and there could be one or two questions just coming in. No, I think we are good. We are already out of time. So thank you so much, doctors. This has been a brilliant panel discussion. Thank you so much, Dr. Mirudhubashini. I know you were not well and still you've gone ahead and done this entire panel discussion, taken it up on yourself and done it. Dr. Ramya, thank you so much. You've been absolutely brilliant, is all I can say for you. And I would like to take this opportunity and thank you on behalf of the PCOS Society and Vijayata and Dr. Darusha, Dr. Shobna, Dr. Ruby. We are all here just to try and, reach out to each and every one out there to tell them what PCOS could be, as we all know that it could become worse because we already have 1 in every 5 men already have PCOS. So we are trying to make this so audience, whoever is there, please do reach out. Please do tell, your friends. Your daughters to session altogether. If there's any questions, you can write to us as well. So thank you so much, Doc. This has been great.
Thank you.